I did record also the other day, and we're trying to find where it is because we don't know where it went to. So I will record on this computer, and I will also record on the cloud. All right, so you had asked me about Coxavalga, Coxavara, and antiversion, retroversion, and if one would cause the other. And in my experience, I've not seen one cause the other. However, there was a pediatric site and a pediatric person that I had spoken with, and pediatrician, and the rotational component of an anteverted hip can result in someone having a coxavalga. Can't explain why, but that was the response. So, and that's the only thing that I know about one causing another to happen. So bottom line here, guys, is for you, I just want you to know the difference between a coxavalga, making an appearance of a long leg, coxavara, a shorter leg, and the angle difference. You know, it's 125 degrees or greater than 125 degrees, less than 125 degrees. Anteversion resulting in a pinch toe appearance or patella squinting or inversion of the feet as you walk, and eversion or retroversion being out. And as and I also said to, who was it? Not Steve. Dave. Dave said he's a retroverted walker, and Dave, were you going to videotape yourself so that we could look at you walking in retroversion?
Yeah, I can do that.
And you also have an X-ray that you're going to provide, right? So
yeah, I can upload that all this weekend. I'll have,
okay, so maybe we can take a look at that.
Videotape me.
And we have a little bit more confirmation of what they are. So all I want you to know is that you have a decrease or an increase in angle resulting in a coxavara or coxavalga. You don't even have to go, because there's a lot of variations in what happens, especially when you look into pediatrics, and when we talk about these congenital deformities, it's associated with something that's happened in utero, or it's maybe an endocrine problem, or it may be a breech birth, or it may be hereditary, and there's a lot of reasons, and it gets very complicated, and people have different experiences about what is happening. But if you think about a coxavalga at the hip, you're thinking about a genu varus at the knee because of the way the bones are, and the opposite occurs with a coxavara at the hip and a genu valvum at the knee. But that's not the only reason you could have these things. And you could have torsional injuries like femoral fractures and a compound femoral fracture. You could have a malalignment, or you could have a torsion. You could even have tibial torsion. So it becomes extremely complicated when we talk about the angles that occur. All I want you to know is that a coxavalga not in utero, but congenital coxavalga is if the angle is increased, and if the angle is increased, it gives the appearance of a straighter, longer leg. And if it's a coxavara, it will give the appearance of a shorter leg. I mean, it even differs when you talk about, is the foot pronated, is it supinated? That also depends on what's happening at the foot as a result of what's happening at the hip. Okay? So just know that we talk about the retroversion and we talk about anteversion. This is a transverse plane movement. And transverse, you always think about rotations, right? Transverse planes. When we think about frontal planes, we think about ab and adduction. So thinking about the frontal plane of a hip problem, if it's a frontal plane movement, the hip moves out and more superior, that's a coxavalga. If it's adducted and more inferior, then that's coxavara. That's all. You don't really have to go even into that detail. I just want you to know basically what's on the slide. Okay?
I just have a quick question.
Mm-hmm.
So I know last class we talked about the leg length discrepancy. When you say coxavera and coxavalva give the appearance of a shorter or longer leg, does that mean it just looks longer or shorter, or that it actually is?
No, it means you're probably going to have an apparent leg length discrepancy and not a true leg length discrepancy. Yeah.
Okay.
Okay. So we know what we talked about: osteoarthritis. We talked about leg length discrepancies, true measured from bone to bone, apparent measured from umbilicus to malleolus. If we measure from umbilicus to malleolus, and there's a leg length discrepancy, we would certainly have to measure from the ASIS to the median malleolus to find out if it's true or not. If it's true, we then make the determination: is it in the femur or is it in the tibia? And outside of doing an X-ray, do I have those pictures? Outside of doing that X-ray, remember we looked at somebody from the side. What's the picture here, right? Okay, here. We looked at somebody from a lateral view and an anterior view. And what do we see from the anterior view? We could see the length of the tibia. What do we see when we look at somebody from a lateral view? We could see the length of the femur. So that's how we can make an educated guess where this leg length discrepancy is. Okay? There's other ways to look at leg length discrepancies, and that's a little bit more advanced, but you could abduct your leg and look at the level of the ASIS. If the ASIS remains level, it's not a true leg length discrepancy. But then again, that goes into more something that you're going to probably learn next year. Okay, so for now, let's just understand that there's an apparent and a true leg length discrepancy. We talked about AVN, avascular necrosis, and that's death of the tissue itself, where the head of the femur starts to die off, and obviously it becomes very painful. Piriformis syndrome, tight piriformis. Why does somebody complain of pain down the entire limb? It's because they usually, I say usually, there are anomalies. There are some people that don't have the sciatic nerve running underneath the piriformis. Some people, everybody's different. You know, some people's heart is on the right side and not on the left side. So that's an anomaly that you really can't control for. But if you're thinking somebody's got tightness in the external rotators, piriformis may be a culprit of causing, because it's hypertrophied or because it's compressing, that piriformis is going to, that patient will really have pain, and they say the pain is really in the butt. And how do you feel the piriformis? Well, we would be doing massage probably next week, but since we can't physically be there, we won't be doing massage. But one of the things that we do use is we use our elbow when we look in the middle of the butt. We know that the piriformis is from the anterior sacrum to the lateral side of the leg to the greater trochanter. So we follow the course of where the piriformis will be. We place our elbow there and we work on the piriformis. Okay? Avascular necrosis, we said, was death of the femoral head. Piriformis syndrome, we looked at this picture. So being that the sciatic nerve is coming from L4 to S3, running posteriorly down the leg, you can have symptoms throughout the whole limb, including the foot itself. There is this was an interesting case. I had a patient with this. I only had one patient in my entire life that had this. Neuralgia paresthetica is pain in the lateral thigh, and it's secondary to compression of a nerve that is purely cutaneous in nature, the lateral femoral cutaneous nerve. And that nerve supplies the lateral thigh. Okay, so here's a picture of it. Neuralgia paresthetica. It's coming from it's a femoral nerve, so L2, 3, 4, L2 and 3. It's a cutaneous nerve, so it's just sensory. So it comes here, underneath the inguinal ligament, and it services the lateral thigh. I had a patient that had complained of tingling and numbness, in my house here, tingling and numbness down the lateral side of the thigh, and it was painful. And we couldn't figure out what it was. A physiatrist sent this patient in to me, and I couldn't figure out what it was. I mean, any test I did, it was all negative. And wound up, he showed up one day after work, and I said, "Oh, that's it," because he was a policeman. So when he came in, he said, "Oh, gee, I'm sorry, I couldn't get changed." And he had his holster sitting not on top of the iliac crest, but down around the lateral side of his thigh, and he was compressing the lateral femorocutaneous nerve. So when we adjusted where he was wearing his holster, he stopped coming because the pain went away. Okay? So that was the compression that was causing the compression, the tightness of his holster around the thigh was compressing the lateral femorocutaneous nerve. And that's known as neuralgia paresthetica. Okay? We know what these special tests are. Thomas test is test for tight iliopsoas rectus TFL, Ober's for tight ITB. 90-90, we know is it as long as the lower leg is 20 degrees from the vertical. Some books say 30. Little variation there. That within from full extension that someone has tightness. And obviously there are numbers associated with minimal, moderate, maximal tightness. And those numbers also vary. SLR test is known as the Lasake test, where the examiner performs this test, and it's a passive test. So you're going to flex the hip, and as you flex the hip between 30 and 70 degrees, you should have a stretch of the sciatic nerve, and that indicates something of neurological pain. And as we flex that, as we confirm it by flexing the cervical spine, as well as dorsiflexing the foot, it increases the stretch of the dura, and it gives us more of a provocative test. Okay? So Thomas test, this is a picture of somebody in supine while they do it. I found this test online. I don't like this test because I like to add the sitting portion of it so that you could see also tightness of the rectus as well as the TFL. So in this particular picture, if we look at this here, what tightness do you see? What would this indicate?
Hip flexors.
Yeah, hip flexors. Hip flexors. And do you see the foot turns a little to the lateral side? Can you see that in this picture?
Yeah, is that like tension back?
That would be TFL.
Yeah.
You think? It's hard to tell whether this is an abducted leg or if this is an externally rotated tibia, which is interesting, right? And I'm going to wait for you guys to do the rest of your test home because I'm going to ask you some questions about the specific test. I'm not going to give you the answer, but I want you to think about this. Okay? I want you to just think about it.
Is it appropriate to say that this could also result in like rectus femoris tightness, or is it like false negative because they're laying on the table supine and their knee isn't off the table?
Yes, I wouldn't say anything about the rectus with this test. I wouldn't be able.
Okay.
Would be like piriformis or something. I guess like pulling it and stuff and the great choke cancer.
You're asking about the foot being out? Is that what you're commenting? Or you're
Yeah, I mean, you said that the hip is externally rotated, right?
Well, we don't know. We don't know.
Okay.
We don't know if it's the hip or the tibia, right? We don't know that from this picture. Different things in their videos, and we could bring this up. And when we do, I'll bring it up. I'll definitely point it out to everyone else. Okay? All right. So here, we've done this a lot, but if the thigh does not approximate the table, it's the iliopsoas scoop. If the leg is not perpendicular to the floor, it's the rectus femoris. And if the leg is abducted, it's TFL tightness. Right? We all agree with that. Okay. Over his test, he has it flexed a little bit too much for me, but again, we're going to abduct the hip, slightly extend the hip, flex the knee to 20 degrees, and we're looking to see if there's contraction of the TFL. Right? If the leg does not approximate the table. So in this case, and if you look at this picture, it's not a great picture because the body is angled. And this is something you guys have to make sure of when you perform this test, that the person is absolutely straight and you're stabilizing the pelvis. I think that this picture is the way it is because they just didn't want him to, whoever was taking the picture wanted to show more where he had his hands and the distance from the table, but you would stabilize the pelvis. Okay? Straight leg test, also known as Lasake. provocal dural or root signs. So the patient's fine. It's a passive test. You're going to raise the leg up. If you raise the leg up and the patient has pain between 30 and 70 degrees, and they're complaining of radicular symptoms, we dorsiflex the foot or we flex the cervical spine. Okay? Sometimes we have a well leg sign where we flex the opposite, we're doing SLR to the opposite limb, so well leg sign, or cross leg response, where they'll have pain if they have a medial disc problem. But again, we're going to talk about that when we talk about traction. So right now, just know that you have an SLR. If you feel that it's positive, we can make it more sensitive by flexing the cervical spine or dorsiflexing the foot. Okay? The sign of the buttock, if I get to here, and I discussed this with my group today, if I get to here and the person has radicular symptoms, and then I flex the knee, and it's truly just a disc problem, what do you think the person's going to say? Will it feel better or will it feel worse? Or will it feel the same?
It could go away.
It should go away. Why?
So better, they'll feel better.
It'll feel better. Why?
Less stretch on the hamstrings.
Well, this is not a hamstring test, though, right? This is test for radicular symptoms.
Less slack in the sciatic.
Less slack on the side. There's more slack on the sciatic nerve, so you're gonna give it slack. You're gonna reduce the tension on the sciatic nerve as you flex the knee, and then as you flex the knee and go up, it's gonna even feel better because you're not gonna feel any pain. You're not stretching the nerve. Okay. Well, it might not get better, but you're not going to feel any pain. The sign of the buttock, if you get up to do that straight leg test, bend the knee and continue, and if the person still has pain and you continue bending the hip and knee, doing passive hip flexion, and the pain gets worse, that's indicating there's something more serious going on. So it could be a cancer, it could be a bursitis, initial bursitis, it could be a specific space-occupying lesion that's very large, it could be an abscess, it could be a pathological fracture. So there could be a fracture of the hip, maybe that was hairline that no one noticed, and now it's, now this person has a true hip flexion fracture or pelvic fracture. So if they have pain as you continue to do it, that's known as the sign of the buttock. Okay? So an SLR, pure straight leg, sign of the buttock, do a straight legs raise, flex the hip and knee, continued flexion, indicates, and the patient complains of more pain. Okay. More pain in the butt area. Faber's test, also known as Patrick's test, is a four-way test. That's test for flexion, abduction, external rotation. What do we look at? We look at groin pain for hip problems. We also look at pain in the back for SI. Okay? Faber's test, four-way. Dermatome. Now,
Professor?
yes.
Hi, I was wondering, how often do you do the Faber's test in your experience?
I personally don't do it that much because I have other tests that I use. However, this one is a very common test that's used. This gives me sometimes I use it as a quick test to rule out something else, but usually if I'm doing an SI, I'll probably do more the compression and distraction.
Yeah, because it sounds like it's a very general test. It's not very specific.
And as I said before, if you want to look at tests, there's more tests out there than you even want to know about. But and usually what clinicians do is they do the same test because they're used to doing those tests and they're very happy with some of the success they have in the test, so they use the same test. But this one is used sometimes. I usually don't use it. Dermatomes. There was a question from Andrew, or a comment from Andrew saying dermatomes are very varied. Yes, they are. Yes, they are. As you could see in this I particularly like this slide for dermatomes. But there are, as long as you know that they are spiral in fashion and they're coming from the lateral and going to the medial, and L3 there's L1 starts from the ASIS, goes down, L2, L3. L4 usually incorporates the big toe, sometimes L5 does. Not a big deal, okay? Because there is some overlap here. Dermatomes, area of the spinal nerve innervating specific areas of the skin, right? So L5 is generally the dorsum of the foot. S1 is generally the lateral side. L5, pretty common down here, innervating the bottom of the foot. S1, usually the lateral side, and S2, the medial side. Some books say S1 to here, and and S2 on the upper side. But I think more specifically, you'll see them split up here. And L4 staying on this medial side, L5 staying on the lateral side. Okay, so L4 here and L5 here. But I think that what Andrew put in writing is good because there are variations of this. I just, like I said, happen to like this one because this is more what I find when I test. L1 is here, L2, L3 down here, L4 crosses. So this is crossing the knee, going down to the medial side, L4. Again, medial side down to the great toe, L5. And sometimes I even say L5 starts here, and some books do say that also. There's a lot of variation in these dermatomes. But basically, you would know upper side from lateral to medial, upper side from lateral to medial, above the knee, at the knee, below the knee, to the medial side of the leg. Most of the toes, excluding or sometimes including the great toe and going up the lateral side of the leg, and S1 being the pinky toe on the lateral side of the foot, going up the lateral side of the leg. Okay, so if you use terminology such as that, that would be perfectly acceptable. S2, 3, and 4 are always, what did we say the other day? What did we call this? There's tingling and numbness associated with this area. What do we call it? I use the example of sitting on a bike or riding a horse. What do we call it?
Saddle.
Saddle paresthesia. Yes, because it innervates, S2, 3, 4 innervates the bowel bladder. This is a red flag when you're working with somebody who's got an HNP. If they have incontinence of any sort, that's a red flag. Okay? And that's sometimes it's just up to you to ask that patient. You know, maybe that patient doesn't want to say, you know what, I'm getting up and I'm starting to lose urine, or I'm walking around and there's a spritz of urine, or, you know, I'm really having problems with my bowel. Because they don't want to really volunteer that information. So you ask them, is everything okay with your bowels and bladder? And if they say, what do you mean? Say, well, you having any accidents or anything going on? And the person says, yeah, as a matter of fact, you know, I'm starting to feel like I can't hold my urine. Okay? And you want to know, has that been a problem before? You know, if the woman, and if it's a woman and she's had multiple pregnancies and she's got weak muscles, weak pelvic musculature, she may have a problem with incontinence. That's not the same as if somebody, okay, since you had this injury, or since you had this problem, or since you had this low back pain, is this something new? All right? This is a red flag. Dermatomes. Hip pointer. This is a misnomer because it doesn't really happen to the hip. This is a bruise on the top of the pelvis. And it is associated with some kind of this black and blue area. Anybody know what this black and blue area is called? If somebody has black and blue, what word do we use for that?
A contusion?
Contusion, or anybody else? Ecchymosis? Ecchymosis? So the area is ecchymotic? Yes, it's an ecchymosis. 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 Okay? So it's a bruise, and that's a secondary to some contact sport. And it's known as a hip pointer. Okay? So it's not really at the hip itself. It's a, and you could see it here. All right. So there are some disorders. These are congenital hip dislocation, also known as dysplasia. You could see a high riding. This is a high riding congenital hip dislocation. So where should this femoral head be? You see it here, right? This is an X-ray of it. I have an arrow. This is where it should be. Okay. So this baby was born this way because maybe this was a breech birth, or maybe in utero there wasn't enough room for this hip, and it displaced, and they may just have family history of it. Okay, so this acetabular is shallow, the femoral head slides upward, and that's all a congenital hip dislocation is.
Now, Professor, would you ever see that like in a clinic, guy just coming in like you would see like a shoulder dislocation?
No.
Is there a way of like repairing that, like through surgery, or is it not? Does it fuse with the bone?
What they usually do is they bring it down, they put the patient in a cast. This is a baby, a spico or something like that. They abduct the limb and make sure the femoral head stays where it needs to be. Yeah. And sometimes they don't always notice that. You know, they may notice it as it is dislocated. As they start to bring the baby home and start to change the baby, and then they hear a clunk when they move the leg, and they know, and then the baby cries, and then they'll go and take the baby in, and they'll do an X-ray and see that there's a dysplasia. All right, leg calf Perthes disease is also known as coxoplana. What's coxoplana mean? This is a temporary condition also. Coxoplana, anybody know what that means? This condition is also idiopathic. What does idiopathic mean? Unknown. Etiology is unknown, right? We don't know. So it's idiopathic. We don't know why it happens, and it's temporary. It happens in children. And what happens is the femoral head starts to lose its blood supply. And as the femoral head starts to lose its blood supply, the bone collapses, becomes inflamed and irritated. And that's painful. So you'll see a child start to limp or start to, grimace or complain of pain down in the groin area. And over time, the body will absorb the dead bone cells, and they'll replace them with new ones. So in the event it comes back and it comes back whole, it's not a problem. But there are some times when you wind up with a coxoplana, and that's more of a flat femoral head. So, and that may become a problem later on in life with these children. So what do you think this child grows up to have if everything doesn't become reabsorbed and replaced as it should?
Osteoarthritis.
Yeah, you wind up with hip arthritis that eventually may lead up to a hip replacement. You don't see this so much anymore. I mean, when I was working out in the many years ago, I saw about two gentlemen that were in their 30s that wound up with really severe OA that wound up with hip replacement. But because right now everybody's more aware of this. Okay. So leg calf Perthes disease. You see this femoral head compared to this one? You see the epiphysis here?
Yeah.
And you see here that the head starts to crumble.
When you see an adult like have osteoarthritis or like a hip replacement, like could you see that it could be traced back to this, or like do you just say?
Well, yeah. Sometimes you say to the patient, "Well, do you ever remember? Have you ever had pain in your hip before? Do you ever have fracture?" Usually you say that. And a patient, and not so much like I say nowadays, but years ago they used to say, "Yeah, I remember as a kid I used to limp a lot." And my mother really never took me to the doctor because she said, you'll grow out of it. And it started to feel better, and I stopped limping, and then it started to heal, but it healed and it didn't heal properly. So they wound up with a flat head. So now, instead of that head spinning around at acetabulum and getting every point of the femoral head approximate every part of the acetabulum, you only had this. So you didn't have this. So what happens over time? This starts to disintegrate, and you start to get cartilage degeneration. Okay. Again, another childhood thing, a slip capital femoral epiphysis, and what happens here is the head will slip off the neck. And a major factor of this is either some kind of an endocrine disorder or obesity. So the proximal epiphysis will slip from its normal position on the femoral head. And you see it usually as the kids start to grow. And this is what it looks like. So here's the proximal epiphysis, and it slips right off the femoral head. Okay. And that's what that is known as. All right. Trochanteric bursitis, we mentioned the other day. We said we have inflammation of the trochanteric bursa, and you can have a compression and friction of that bursa from something that's short. So it may be adaptation or adaptively shortened TFL, as well as what other muscle? Gluteus maximus, right? Gluteus maximus, because it inserts into the ITB. But
I have a question about this one. When you're doing the Ober's test and experience pain alongside that trochanteric bursitis, can we not do the Ober test or?
no, you certainly can. You certainly can do the Ober's test. There's no reason why you shouldn't do it. But if they're having pain directly, and it's really pretty, that patient points right to that trochanteric bursa. What do you think they do for it? If this person is seeing a physician at the time, what do you think they do?
Drain it?
Yeah, you do a steroid injection. You give a little injection, cortisone injection. Not a steroid, it's cortisone injection. Well, cortisone is steroid. You do a cortisone injection and it's to relieve it. But you also have to make sure that this person is walking properly and that TFL isn't constantly pulling that IT over. You know, you have that balance, right? You look at the model, or you look at where the muscle is coming. You have the glute max on this side, you have the TFL on this side, and they're meeting, right? They're meeting. So if one is pulling more than the other, then either the band is going to pull in an anterior or posterior direction.
So usually for bursitis, is the pain that the patient will experience is most likely local. It's not like it's radiating anywhere.
It's local. It's local. They can't lie on it. It's hot. It's burning. It's painful.
Yeah.
It's a certain movement. Yes. Okay. So we see that IT over that bursa. And this is all repeated friction over the lateral femoral condyle during knee motion. We talked about iliotibial band syndrome before. So there's lateral knee pain because the IT band goes over to the lateral femoral condyle and into the tibia. And also can be affected when your shoes are worn out, right? Also can be affected if you run the same circle the same way all the time, or you run on the street and the street is pitched. So one side you're going to create a short leg on one side, a longer leg on the other side. Not really going to be structurally, but functionally it's going to be longer or shorter. So all these things can cause an IT band syndrome. Okay, so you need to know that. Here's the anatomy, here's the gluteal muscles, here's the IT band and TFL, right? So normally the person will complain of pain right around where the IT inserts. All right, muscles of the hip, we know that on the one joint muscles move at one joint, two joint muscles move at two joint, are more susceptible to, what's the word? Passive insufficiency. You can group the muscles by location as well as function. All the muscles on the anterior side, most innervated by the femoral nerve, they're flexors, posterior or extensors, medial side adductors, and lateral side abductors. Okay, we know the difference between the one and two joint muscles. So if I ask you this on the test, iliopsoas is a one joint, rectus femoris and sartorius a two joint. What muscles become or insert into the pes anserinus? Rodney.
I'm sorry, say that again? You got cut off.
What muscles insert into the pes anserinus?
Sartorius, gracilis, and semitendinosus.
Excellent. Good. All right. Iliopsoas, we said were two different muscles innervated by the iliacus as well as the psoas major and minor. And sometimes the psoas minor is the psoas major on top or underneath the psoas minor? What comes first?
Minor's on.
Yeah,
Major.
minor, T12 and L1, right?
Major carries the minor, right?
Yes. Okay.
So two separate origins, common insertion.
Yes, we know that. Two separate, my kinesiology professor here is saying two separate oranges and one common insertion. We know that, right? Okay. Tectinius, we know all these muscles. These are just a review. The deep trochanteric muscles, we know basically what did Kevin tell you to say as far as an insertion. When you need to guess, you say greater trochanter, right? And they're all deep external rotators. And this is how, I know you have a different way to remember these, right? These goods often go on quilts. You have something go on quaaludes, something like that. Play golf or go on quaaludes. Yeah. There's a lot of different mnemonics for this. No, I'm not going to say it's the dirty one. My husband's saying there's also a dirty one. I'm not saying.
Say it.
No. All right.
Quaaludes are more fun, that's fine.
Hamstrings, we know. The important thing about hamstrings is they attach down here, right? So if they attach on the tibia and the fibula, do they have an action at the tib and fib? Do they?
Yeah, the flexion.
Is that all?
Wait.
Internal rotation and external.
Oh, you mean that thing?
Like,
Yes. They could internally or externally rotate the tibia. So when you do your SLR, or when you do your hamstring stretch, or your hamstring length test, when you go to 90-90 and then bring the lower leg up and the toes point outward, why is that happening?
It's externally rotated.
because of the bicep femoris.
Correct.
Right.
Correct. Okay. Semitendinosus, semimembranosus, which one's deeper?
Which one? Sorry.
Membranosus.
Membranosus.
Membranosus. Biceps femoris is it's also a two-joint muscle, right? Has two heads. Which nerve innervates the short head? This is innervated by the sciatic. Oh, it's right here. Well, remember when I told you guys, I said that the sciatic nerve is in a common sheath. And then in the thigh, it branches off and throws specific segments off to the common peroneal. The common peroneal is innervated in the short head. Yes.
Semimembranosus insertion is more medial, M&M.
Semimembranosus insertion is more medial. M&M. More medial. Okay, but we know that the semimembranosus is also inserting into the condyle of the tibia, and the semitend is not. It's inserting onto the medial upper proximal tibia. Okay. Gluteus medius. What's important about the gluteus medius?
The Nullenberg.
Primary hip abductor.
It's a primary hip abductor. We have an anterior gluteus medius that's important in internal rotation. Posterior gluteus medius, important for external rotation. Okay? So what muscle do you think would compensate for this muscle or not? I should say, yeah. What muscle would work, what muscle does almost everything this muscle does except for internal rotation?
Glute max. Gluteus maximus.
Okay. What about the TFL?
I was going to say
I was
GF.
going to say that.
Damn it.
So a lot of times, when you're working with people that appear to have hip problems, what they do, and think about some different occupations or recreational stuff they do. So somebody who rides a cycles 20 miles a day. What position is their femur in?
Oh, internal.
Internal?
Internal rotation. Right. So if you test these people, a lot of times they have pathology, hip pathology of pain, or they have compression of the hip, and they have femoral anterior impingement. So they have pain within the femur itself, and you have an impingement because the head of the femur is not rotating the way it should because it's being held so tightly there from the TFL because the person is not using the gluteus medius posterior. Okay, because the gluteus medius posterior needs to abduct and externally rotate. And a lot of times when you test these people, they're able to flex and they're able to abduct their leg. And when you put them on the table in the sideline position and you ask them to abduct and you put resistance above the the lateral malleolus, they will flex their hip in an attempt to abduct it. And they will flex and internally rotate their hip. So they will use the TFL rather than the gluteus medius. Okay. Minimus underneath it, reversal of function. We were talking about that today in lab, and then I'll end here. So the distal segment, the femur, becomes more stable in the proximal segment. So the origin moves toward the insertion instead of the insertion moving to the origin. So we talked about Trendelenburg gait, right? So without contracting, the pelvis would drop on the opposite side. We know this. If we have right hip abductors, we're going to stand on the right. The left side will drop. How we compensate for it to keep our center of gravity of our base of support? By leaning to the right. So we were doing a gluteus medius lurch, right? So in reversal of function, the right hip abductors contract to keep the pelvis steady when that leg is lifted. When the right hip abductors are weak, the left pelvis will drop, right? Look at this picture. When the foot is on the ground, right? So the foot is on the ground, closed pack position. The thigh isn't free to move. When the gluteus medius contracts, the force of its pull is exerted on the pelvis, pulling it in a downward direction, known as depression or lateral tilt of that side. If one side of the pelvis is pulled down, the other side is elevated, and the major function of the gluteus medius is to stabilize the pelvis when this downward direction of pull. Okay? So if you're in a weight-bearing position, then the pelvis will drop with reversal of function to elevate the hip on the other side. If this muscle is not strong enough, you're not going to have that happen, and you're going to drop this side. So we have a depression of the hip, and as the hip drops on the other side, you have to do a lurch on the side that's weak to pull up the hip that's not being held level by the weakness of the gluteus medius muscle. Okay? So that, therefore, when we test that gluteus medius, we test it in the weight-bearing position. All right? We can notice it as somebody's ambulating. But if we want to confirm that this muscle is truly weak, what do? We put the person in the sideline position. We ask them to abduct their limb. We hold the limb up. Initially we place resistance above the ankle. But remember, we have a better mechanical advantage, don't we? Because the lever arm, the resistance arm is going to be a lot longer than the force arm. Because the force arm is only going to be from here to here. So there are times when we need to take our hands off the ankle and place it above the knee to test this muscle. Okay? But know, and I will go over this again next semester, that when we do that, we can't give this person a grade of normal because that person should be able to lift that limb against gravity with maximal resistance. Okay? All right. And that's it, because this is all pretty much a review. We know where the course of the sciatic nerve is, and I will send you the knee and ankle, and we'll finish that on Tuesday. We'll do the whole lecture. Okay? Any questions?
Those of you who want to hear the dirty mnemonic for the external rotators, stay on after she closes.
Put them in the call.
Okay?
The goat.
The goat. Get them in the chat.
All right. All right, we good with this? Any questions, just let me know. But Andrew, your question was noted, and I just wanted to address it with everyone here. I can
That's good,
also
thanks.
provide you with another picture, which I pulled out, which might help, and I'll send that too. Okay?
Sounds good.
And we'll let you guys know about the uniform, and we'll keep you posted via email.
Thank you. Actually, before I forget, I just have one question about the favors. If there's no pain, if there's total tightness, that occurs, but there's no pain, so we just assume that there's the person just has immobility in those muscles.
Yeah, they have tightness. Yeah,
Yep.
so the internal rotators are tight and they're restricting the external rotators. Yeah.
Yep. Excellent. Thank you.
Okay. All right, it's been a long day for some of you, so enjoy the rest of the day.
Thank you. Have a good one.
Can you go back to that last slide that you were going over with the abduction and the glute medius? I'm not keeping anyone, by the way. You guys can head out or whatever.
All right.
You're absolutely keeping me.
I'm here for the mnemonic, man.
Yeah, so, I wasn't sure. Okay. On the figure B, so just to be clear, you do experience hip drop on the opposite side if you have glute medius weakness, but in this case, it's because of the compensation, because he's leaning to the right in that figure.
Yes.
That's the only reason why it's elevating. Normally, it would be tilting down.
Well, the gluteus medius holds the pelvis level or elevates it slightly on the opposite side when it's strong.
When it's strong.
Yeah.
Right. So if it was weak, in this case, it would be the left hip would be dropping, but it's just because of that compensation that it's raising.
Correct.
Okay. All right. Thank you.
Okay. This is reversal of action, isn't it? Because this is what the gluteus medius does. Here's the reversal of action causing that other hip to come up, which is normal. So don't think that's abnormal, Chris.
Mm-hmm. And it's because the leg is fixed.
This leg is fixed, yes.
Mm.
This is what the gluteus medius does in a normal bearing leg, right? It brings the femur to the pelvis. Here, the pelvis has to be brought to the femur in normal reversal of action because this leg is fixed.
Yes.
Okay?
Yes.
Okay. All right, guys. See you Tuesday.
Professor, if you just have a minute once, I don't, if anyone else has any questions, I'm just going to hang out in the chat. I would like to ask you something.
Sure.
We're,
Anybody else need? Because everybody else can go. Goodbye, JS.
Here for the mnemonic.
We were promised a mnemonic.
I just stopped recording. Who else is here?